My name is Kate McGregor. Today is Tuesday the 24th of September and this is my airway management video. I will be covering putting a patient into a lateral position, triple airway manoeuvre, insertion of an OPA and an MPA, laryngoscopy and assisted positive pressure ventilation using a BVM. Now I'm demonstrating the lateral side position. This is indicated in an unconscious patient or patients at a risk of aspirating. First off, we check the patient's pockets to make sure there's nothing in them that could harm myself or the patient, and then place a blanket or small cushion underneath their head. Then flexing the patient's leg closest to myself at the knee and crossing the arm on the same side across the patient's chest. Pushing the opposite arm out to a 90-degree angle. Then position yourself close to the patient's hip, placing one hand on their shoulder, one hand on their hip, and gentle rotation away. Then bringing this leg forward to stabilise the patient and this arm forward next to their head. This prevents them from rolling further over. Then just an extension of the head to open up the airway and allow for free drainage of any fluids. I'm going to demonstrate the triple airway manoeuvre. This is used so that the patient's airway can be properly inspected to make sure that it's patent. Because I'm doing this on an adult patient, we prop the patient's head up with a cushion so that the tragus and the ribcage are aligned and we know that the trachea is straight. Before I start, I'm also going to inspect the patient's airway, just briefly, just to make sure there's no obstructions and if there are any, suction them out if it's required. First, I place my right hand on the patient's head with my thumb pointing towards their nose and tilt the head back. It's important to avoid hyperextending as this can occlude the airway. Then I place my left hand on the patient's chin, holding onto the jaw and also the chin, lifting it up so the tissues and the tongue are moved out of the way. Then I bring my right hand around with my fingers underneath the mandible and my thumbs on the cheekbones, retract the jaw upwards so that I maintain the first two steps of this procedure. And now the airway can be inspected. This differs from the sniffing position in that the sniffing position is just tilting the patient's head back for use of an airway adjunct. Now I'm going to demonstrate insertion of an oropharyngeal airway. Before this is done, you just need to place a blanket or a cushion underneath the patient's head. The insertion of this airway may also be done after performing the triple airway manoeuvre and after a brief inspection of the patient's mouth just to make sure there's no obstructions and suck them out if required. The OPA is used in an unconscious patient to maintain forward displacement of the tongue and is contraindicated in any patients with a gag reflex or trismus. Before you can insert the OPA, it's important to measure it and make sure you have the correct size, and this is done just by comparing the OPA from the corner of the patient's mouth to the angle of the jaw. If the OPA is too big, this can damage the tissues inside the patient's mouth. Before insertion, the OPA also needs to be lubricated. This can be done using the patient's own saliva. Then the OPA is placed initially upside down into the patient's mouth with a 180-degree rotation about halfway in until the flange rests against the patient's lips. This is done to stop the OPA from pushing the tongue in backwards and to support it fully once it's in. When the OPA is inserted, look, listen and feel to make sure the patient is still breathing, and then pull it out if they have a gag reflex. I'm demonstrating insertion of a nasopharyngeal airway. This is indicated for unconscious patients to maintain an open airway where insertion of an OPA has been difficult or contraindicated. Contraindications of an NPA include any patients with middle third facial fractures or trauma to the nose. Before you can start, the patient's head needs to be put on a cushion or towel and the triple airway manoeuvre needs to be performed. The NPA also needs to be measured so the correct size is used, and this is just done by measuring from the nose to the earlobe of the patient. Then the NPA needs to be lubricated. Before you insert, you need to make sure that you come in at a 90-degree angle, as any patients with evidence of a basal skull fracture, you can do further damage if you come in any shallower. Gentle insertion with a rotating motion, stop if any obstruction is felt, and continue inserting until the flange is flat against the patient's nostril. Make sure the patient is still breathing and remove if there's any gagging. Now I'm going to demonstrate use of a laryngoscopy. First, you need to make sure your patient's head is placed on a small pillow or a towel and checking your equipment to make sure that the light is white, tight and bright. Then, placing your right hand on the patient's forehead, tilting the head back into the sniffing position and picking up your equipment in the left hand. Insert the laryngoscope into the right side of the patient's mouth, sliding across to the left into the molecular groove, making sure you lift up instead of using a hooking motion. This is so you don't chip the patient's teeth or induce choking. Lifting until the vocal cords are in view and you can observe for any foreign objects that may be in the oropharynx that can be removed via suction. Now I'm going to demonstrate assisted positive pressure ventilation using the BVM. Initially, your patient's head needs to be on top of a blanket or pillow and an OPA needs to be in situ. Getting your BVM and making sure you have the correct adult size mask for an adult. Place the mask over the patient's nose and mouth using your thumb and second finger in a C shape and wrapping your third, fourth and fifth fingers around the patient's mandible. Then squeezing the bag to give about 10 millilitres per kilo of air to the patient. Check for adequate rise and fall of the chest to make sure that the patient is getting air, and be careful to not overinflate the patient as this can cause barotrauma.